World Anesthesia Day, which is going to be tomorrow, or one day earlier. And before we get on to the meeting, I just want everybody, to all the delegates, to remind you about the Zoom etiquettes we have to follow during the Zoom meetings. I don't think I have to repeat everything. We all know how to be present in front of the video and how to unmute ourselves and not to disturb the proceedings of this meeting. And the WhatsApp number for CME credit hours has been notified in the chat box, and you can send your name for credit hours to get the form to fill in your details. Now I request Dr. Brinda ma'am, our President, Salem branch, and the HOD, Department of Anesthesiology, GMKMGH, to give a welcome address.
Thank you, Lavanya. Good evening, one and all. On behalf of Salem ISC, I am happy to extend a warm welcome to our State President, Dr. Sudarshan, State Secretary, Dr. Kripagar, President-elect Dr. Kumar, State Treasurer, Dr. Ratna Kumar, Moderator and Academic Coordinator, Dr. Edwin Johnson, sir. I am also privileged to extend a warm welcome to our speakers, Dr. Parthasarthi from Pondicherry and Dr. Bhavani from Vellore. It would be most appropriate today to remember and be thankful to Dr. W.T.G. Morton, before whom surgery was painful, by whom pain in surgery was annulled, and since whom science has conquered pain. This year, our ISA, along with World Resuscitation Council, has laid down 3 strategies: safety for all, professional well-being in this troubled pandemic time, and imparting knowledge to restart a heart technique to every citizen of the world. Though patient safety through eternal vigilance has been our motto for long, professional well-being is a new idea that needs to be practiced, because even an otherwise enthusiastic, fully organized anesthesiologist is now being pushed to his or her limits due to the stress, increased workload, interpersonal conflicts, changing guidelines, protocols, and safety measures. We have to learn to strike a balance between family, work, and society by being positive and sharing our responsibilities. Lastly, I would like to place on record today our condolences and prayers to the family of Dr. B.S. Murugesan, senior anesthesiologist of Salem City, who passed away a few days ago. He is survived by his wife and son. Sir was attached to Maytur and Salem GH and was freelancing in Salem. He was a very jovial and friendly person and used to offer excellent advice, not only to anesthetic colleagues, but also to surgeons, especially obstetricians, when they were in trouble. Let us pray to the Almighty to be with his family, to help them tide over their sorrow. Thank you.
Thank you, ma'am. Now I request Dr. Sudarshan, President, Tamil Nadu ISA, to give away his felicitation for this meeting. Dr. Sudarshan, sir, over to you, sir.
Good evening, all of you. Respected President-elect Dr. Kumar, State Secretary Dr. Kripagaran, President Dr. Brinda, Secretary Ramesh of ISA Salem, immediate past President Academic Coordinator Dr. Edward Johnson, our State Treasurer Dr. Ratna Kumar, all the dear friends from ISA Salem and other branches who have joined for today's webinar. It is a great privilege to be a part of this webinar series, and in particular to attend the ISA Salem's event. Earlier, when we used to have a physical meeting, it used to be no distance between Salem, Erode, and Coimbatore, because the West Zone, we all comprised of one single unit. So it had been a great pleasure to visit every time whenever they invited. Now it has become much more closer by these Zoom meetings, so that we are all able to attend a meeting wherever it is held, and just sitting in our hall or your study rooms. So that's the benefit of good sign of we should take it from the pandemic. At the same time, we are all reminded tomorrow about the toils which has been encountered and made by the great person, W.T.G. Morton, before he really convinced the world that there is a specialty called anesthesia which can render someone painless before undergoing any major surgery. So that is the first time, if you all remember, 1970, 174 years now passed, but still we celebrate the day with great enthusiasm, and I'm sure all around the world it is celebrated very well. The Ether Dome is still prevalent, and anybody gets an opportunity to visit Boston, they should visit the Ether Dome and take it as a memorabilia picture there. On this day, I appeal to all my colleagues to carry out your services with pride and passion. That's very most important. Pride of your specialty is the primary thing you should carry it along with you, and the passion of your specialty. These two things drive you forward, irrespective of what the outcome of your support from your colleagues or the institutions and the hospitals where you function. But if you have the pride and passion, your functioning would be at utmost peak. And I'm sure that'll be the driving force. No pandemic, difficulties in hospital, financial stress, stress at home. All these things would be nullified if you have show passion towards your profession, and if you show really take it as a big pride in your armamentarium of skills of administering a safe anesthesia. Today, I remember I was sharing with Kriba, anesthetized one 106-year-old gentleman. 106, that is the oldest I have done so far. 105, I have done regional anesthesia. 106 for a general anesthesia was today. And I was telling that old man that tomorrow is the World Anesthesia Day, and it would have been more fitting to have him the next day. But he said, Doctor, every day is a anesthesia day for you. And I really wish all of you people, entire community of anesthesiologists, really do service to the mankind. This was after he woke up from the anesthesia. So with that pride and of passion towards the profession, I expect all of you to carry that, and in your day-to-day activities, that will keep you going irrespective of any of the difficulties in your practice. And of course, your learning is very, very important. And today we have a lot of opportunity for learning through the e-meetings like this, webinars. And today, excellent speakers, we all know Dr. Parthsarthi, my good friend from Tiruvarur, and he's been a most passionate teacher, I would say. Along with being an anesthesiologist, I welcome him, and he's a good speaker, and we will have an excellent inputs from him. Along with him, Dr. What's her name? Dr. Gomati. Bhavani. We listened to her during our state meeting a few weeks ago, and she is an excellent speaker, and today is also going to be nothing new, and she's going to deliver us a wonderful lecture today. Without wasting much of time, I thank you all for the wonderful opportunity for inviting me as a part of this webinar, and wish you all a very successful and a very memorable World Anesthesia Day tomorrow. And over the weekend, we are going to have a state program conducted on Sunday. I welcome all of you to attend, participate in that as well. And then it will be a definitely entertainer for all of you. Thank you so much for the opportunity. Thank you.
Thank you. Thank you, Dr. Sudarshan, for your kind words and your wishes for the Anesthesia Day. Now I request Dr. Ratnakumar, Treasurer, Tamil Nadu ISA, to felicitate the meeting, please. Dr. Ratnakumar, over to you, sir.
Thank you, ma'am. Good evening, our respected President ISA Tamil Nadu, Dr. Sudarshan, Secretary, Dr. Kribagaran, Vice President, Dr. Kumar, our Academic Coordinator, Dr. Edward Johnson, and the President of ISA Salem, Dr. Bhavani, and Secretary, Dr. Ramesh. Thank you all for the opportunity. Really, the technology has brought us so closer that we can plan and meet how far we may be. And thanks to technology, and as Sudarshan said, the corona pandemic has really brought us together more. And for ISA Salem, every time I have a special attachment towards ISA Salem because to me personally, it's well known for its hospitality. never ever got disappointed. And not only myself, from all the members of ISA Kanyakumari branch, look forward every year for the academic feast and the excellent hosting they will do in Aircard every year with the CME. And this year, unfortunately, because of this corona pandemic, we are missing that. And thank you, ISA Salem. You have always been a well, um, well, very important part of ISA Tamil Nadu. Thank you, and it is well known from our Kibar and sir also. Thank you, and this CME is also going to be an excellent academic feast, no doubt. And we are having good speakers, as Sudarshan sir told, and I'm looking forward to a very great CME. And thank you, thanks for the opportunity, and my warm felicitations to all the office bearers of ISA Salem City. Thank you.
Thank you, sir. Thank you, Dr. Ratnakumar, for your
Thank you.
felicitations. We also, along with you, we also look forward to the next meeting in the aircard. We can't
Yes,
wait no more. So, with this
Thanks a
introduction,
lot.
let us move on to the academic session of this evening. Let me introduce the moderators for this academic session. Today's evening, we have along with us Dr. Edward Johnson and Dr. S. Kumar, who is going to be the moderators for this evening session. Dr. Edward Johnson, I don't think anybody needs, anyone needs any introduction. Dr. Johnson is a well-known senior anesthesiologist and MD from Madurai Medical College. And he had worked as a tutor assistant professor in various medical colleges for more than 17 years. Now he is currently with the Kanyakumari Medical College. He has organized many workshops, including accident and emergency life support, zero error nerve block live workshop, and along with other ventilation workshops. And he has many publications and presentations at the regional and the national level for his credit. And apart from his academic activities in the field, he is very active in the social media also. He successfully runs a website along with a YouTube channel and a Facebook page for anesthesia news. And he had been the past president of ISA Tamil Nadu in the year 2018 and 19 and associate editor of IJA in 2019. And on editorial board with in the Indian Journal of Clinical Anesthesiology and Journal of Anesthesia Forecast USA, and is the past president of ISA Kanyakumari and an international member in the Difficult Airway Society. And he has received the Neon Excellence Award in the year 2017. So with this, we welcome you, sir, Dr. Edward Johnson. I'm not sure whether he's joined the meeting yet.
No, he said he'll join later.
Okay. Sorry, I didn't realize that. Sorry for that.
Okay.
Our next moderator is Dr. S. Kumar, who has worked as a senior consultant and head cardiac anesthesiology and critical care in Meenakshi Mission Hospital for the past 22 years in Madurai. He is the president-elect ISA Tamil Nadu, and he has more than 20 national and international publications to his credit. And he was a scientific committee chairman in the year 2014 for the ISA Con conducted by Madurai, and he is the organizing secretary for the upcoming IACTA Con into 2021 in Madurai. With this, we welcome you, sir, and take over the proceedings for the academic session. Thank you, Dr. Kumar.
Thank you, Dr. Lavanya. Respected President Dr. Sudarshan, our Dynamic Secretary Dr. Girbagaran, Treasurer Dr. Ratnakumar, our Academic Coordinator Dr. Edward Johnson, and ISA Salem President Dr. Brinda, ISA Salem Secretary Dr. Ramesh, and President-elect Dr. Lavanya. And my dear colleagues, a very good evening to everyone. Wishing you all a very happy World Anesthesia Day in advance. At the outset, I'd like to thank Dr. Girbagaran sir and Dr. Ramesh for inviting us to be part of this program. You all know that Salem is known for very good academic feast with the excellent team. They have proven many times. And congrats to the entire team, and keep it up, keep going. I think with that, we will move on to the academic program. We have two excellent speakers today. One is Dr. Parthasarathi and number two is Dr. Bhavani. The first topic is on maternal changes during pregnancy. To deliver the talk on that particular topic, the speaker is Dr. Parthasarathi. Dr. Parthasarathi doesn't need any introduction for this entire August audience, but it is my duty to introduce to a little extent. He is a well-known speaker and very good academician. He is currently a consultant anesthesiologist and professor of anesthesiology, Mahatma Gandhi Medical College, Pondicherry. He has organized a state-level CME in January 2011 and presented around 42 research papers in various conferences. He has received a Tanvindri Award for medical excellence from Honorable Minister Mr. Manishankar Iyer. And also he has contributed for the eye donation and received an appreciation citation from the President, Dr. APJ Abdul Kalam. Beyond that, he is an excellent Tamil scholar. He has contributed to the Tamil in various levels and is a very good academician. With that, I invite Dr. Parthasarathi to proceed for the talk. Thank you very much.
Thank you, sir. Thank you. It is not going.
Your bandwidth is very low, Parth.
Can I share?
Yeah. No, not
Good evening, Kumar. Good evening, Kumar.
Good evening, sir.
Good evening, Edward.
Sorry for the delay.
Oh, no problem. Vanga.
We are just starting.
Okay.
Yeah, now it is seen.
Am I audible? Am I clear?
Yeah, but your bandwidth is very low.
Yes, in pregnancy, at the outset.
No, voice not clear,
At
sir.
the outset, I wish to thank all the office bearers of the state, office bearers, Salem ISA.
Parthasarathi, hello?
What is it?
You can switch off your video. Your bandwidth is very low. You can switch off your video.
Hello, now?
Now better, sir.
No, better. Okay, carry on.
Now it is okay?
Yeah, better.
Yeah, switch it off. I have switched it off. Is it okay?
Okay, sir. Okay. Proceed, sir.
Now better. Better. Okay. Can I start?
Please, sir.
Yes? Hello?
Yes, sir. Please,
Okay.
sir.
So, first of all, at the outset, I just wanted to thank all the actually very active office bearers of both the state and Salem and the state and the chairpersons for giving me this opportunity to talk. Actually, the topic was given day before yesterday or yesterday, I think. One thing I want to tell is about anesthetist. We have only the specialty that we have birthdays. If you go and see pediatrician, don't have birthdays. Cardiologists, they say the September 25 is the cardiology day. A birthday like this, and we are the only specialty to have this. So anything on academics, I put a big salute to the legendary teacher of 2 centuries, Dr. Ravi Shankar. So you can see times now, headlines, NDTV, everything. This is the news. So changes in pregnancy is the news. When so many people are interested to know the
Very good.
changes in pregnancy, why we cannot know. That was the idea, right? Okay. So globally, everyone wants
Parthasarathy sir,
to
your voice is
change. Why not anesthesiologist?
Partha?
Now, if
Partha?
you see the systems involved, it is CVS, RS, CNS, head, eyes, ENT, gastrointestinal, skeletal. Then I went and searched. Wait, the physiology textbook. Hello.
Yeah, your voice is
Yes.
breaking.
Hello.
Your voice is breaking. Partha.
Hello.
Yeah.
Hello.
Yeah.
Okay, I will come out. I'll come out, right. Is it okay now?
Yeah, better.
Better, sir.
Better. Partha, are you there? Edward, good evening.
Good evening, Kripa. What happened?
Yeah, we just started.
Yeah.
Partha's Wi-Fi is very weak, it seems. You can give some introduction to pregnancy changes
Yes, sir.
till Partha is ready.
What?
Yes, joined back.
What? So the peculiarity of physiological changes in pregnancy is mainly to maintain the uterine blood flow. All changes
Yeah.
that happens in the cardiovascular system and respiratory system, anywhere, the ultimate aim is to maintain the adequate uterine blood flow. So the uterine blood vessels are low resistance circulations, and the blood volume is increased, so the viscosity is reduced. So these all changes are to maintain the uterine blood flow, and increased oxygen consumption also increased. So to meet the increased oxygen consumption, the respiratory rate, except the tidal volume, everything increased, respiratory rate increased. So, and there is a reduction in the FRC also to compensate that. There is a increased respiratory rate and increased.
Hello.
Yes.
Yes, sir.
Okay.
Yes. You are audible. Go ahead.
Wait, I'll go again now.
Yeah, share the screen.
Now screen is visible.
Not yet.
Share screen.
Wait, coming. I don't know if this is coming problem.
Yeah.
Is it okay?
Yeah, okay.
Yes, sir.
Wow.
Yeah. It's seen now.
Now it is okay?
Carry on, Partha. Carry on.
Okay. Now the cardiovascular system, now you can see that there is only one thing we have to remember is a chronic volume overload. Number one. There is water retention which exceeds sodium retention. There is a decreased plasma osmolarity. So it comes down from 285 to 275. The cardiac output starts to increase from 8 weeks. Now you can see heart rate and stroke volume both increase, and cardiac output in labor may go up by 7 liters. Now there are two things in this cardiac output. One is blood goes to the fetus. Another is it reduces the impact of maternal blood loss at delivery. Again, I'll come back. Again, I'll come back in a different manner. The hemodynamic changes, you can see systolic, no change. Diastolic, decreased. Heart rate is increased, cardiac output is increased. Systemic vascular resistance is decreased by 20%. Yes, we'll go back again. Now we can see cardiac output in SVR is equal to BP. So it increases, this decreases, and there is no change here. In fact, due to vasodilation, there may be a fever-like situation, but there is an important advantage. There is an easy venous access, but there is some problem. The epidural veins are engaged, so you may get a vascular puncture during epidural. Now, this is very simple. Heart rate increase, stroke volume increase, and cardiac output increase. 40 to 50% the cardiac output increases, and this is more flattened from after 36 weeks. Now I'm going to the most important thing, the wedge and the supine hypotension. Now in normal physiology without anesthesia, patient is lying down, a pregnant patient is lying down, but your IVC is compressed. But still, your veins are strong enough and your muscles are strong enough to push the blood from the lower limbs through the vertebral veins into the azygos and the SVC. Now your IVC is totally bypassed. SVC where it will go and sit. This is now there is a compression of the IVC, but the patient is having no symptoms. This is called concealed cable compression. Cable compression is there, but it is concealed. Now, if you start giving anesthesia, the sympathetics are blocked. The muscle tone is gone. Now, it cannot push into the epidural veins, into the azygos, onto the SVC. So, the patient becomes hypotensive. There is some pallor. All these things are coming. This is called revealed cable compression. Now, that is concealed. This is revealed. There is one more thing I want to very much stress on this is, you think the BP may fall, but sometimes BP may not fall because the baby can also compress the aorta. If aorta compresses, then it is something like an coarctation one. The upper limb BP will be a little higher. So we think the BP is high, everything is fine. But aorta compression is causing the most important problem is the placental circulation is compromised. That is what we have to remember. Concealed cable compression, revealed cable compression. Aortic compression is there. The upper limb BP may be normal, but this is happening with the compromise of the placental circulation. Now, there's one more thing. The uterus does not have autoregulation. Brain has got autoregulation. Kidney has got autoregulation. From 50 to 110, it can. The blood flow does not change much. But we have to depend upon cardiac output and blood pressure to see the uterus is being enough supplied enough. Now you see CVS, the increased splitting may be there. There is S3 gallops, some ejection murmurs, some continuous murmurs. So many things may be there. Now I have one more point here. The vascular response to noradrenaline is decreased. So we may need little higher doses of ephedrine or mefentramin in such cases, pregnant patients. That is one point. Another point is vascular response to adrenaline is also decreased. So the test dose may not elicit the same response. Non-pregnant 15 years, it may not have the same response in pregnant. This is the problem with the vascular response to catecholamine decrease, which happens in pregnancy. There are a lot of things that happen. Straightening of left heart border, heart more horizontal, cardiomegaly. See, some things can happen X-ray, but this is not much because we don't take much X-ray. But many ECGs are taken. This is the study of ECG changes in normal pregnant women is my PhD thesis. There is left axis deviation and non-specific. What happens commonly in our population is there is a shortening of PR interval and there is a WPW syndrome is more than 6 to 8%. These patients go for tachyarrhythmias during, sometimes we can see a lot of patients going to 170, 180 after spinal. These may be due to a WPW syndrome in patients. These changes will disappear after 4 to 8 weeks postpartum. Now we can see echo, LVH. There are so many patients which we can see echo is there, mild pulmonary leakage, mild tricuspid. So many things will be given and patients are bamboozled. So this is 94% will exhibit tricuspid and pulmonary leakage. That is what we need to remember. The upper respiratory tract there is some edema, stuffiness, maybe epistaxis. So think about when you are thinking about an SLT. Airway edema, difficult intubation, large breast mask ventilation. Okay, always keep size 6 tube. That is one of the most important physiological change that gives us some punch to our anesthesia practice. There is one more thing. Mallampati classification in pregnancy, it worsens with months. You see, third month, it will be Mallampati 1. The same patient, if you see in 6 months, there are a lot of edema, some swelling, something changes. So they happen to be Mallampati 3. This is what we have to remember. Now the thoracic cage becomes more AP parameter. These are all again discussed in books. Changes of rib cage and expanding uterus. Now you can see there is one finding is FRC, functional residual capacity. This is the oxygen reserve. Now we are apneic. Patient is apneic. We have given scolia. We are not able to ventilate. That is some oxygen reserve. That is the FRC. That is around 2.4 liters. Other 21%, it will be 400 to 350 ml. That is our oxygen reserve. So if it comes down again to 300, 200, our oxygen reserve is less. So another point is oxygen consumption increases. Oxygen reserve decreases, oxygen consumption increases. They desaturate at 150 millimeter per mercury per minute. For example, now you have kept an oxygen, 3 minutes pre-oxygenation. Non-pregnant is there, pregnant is there. Now you're supposed to PaO2 is 600. Now you have kept it oxygen for 5 minutes, ETO2 of 100 for 5 minutes. You are supposed to PaO2 is around 400. Now, a non-apnea, we cannot ventilate. This pregnant female by 1 minute will come down to 250. But a non-pregnant female will come down from 400 to 375. That is the biggest disadvantage. Increased oxygen consumption, decreased reserve, and desaturate faster. So mild intermittent dyspnea, which is physiological, many patients come. See, they come with echo, mild pulmonary regurgitation. So this is a must-know thing. Mild intermittent dyspnea after around 8 months is normal. You examine that, you find out previously what was all these things, history, and just think that it is physiological. As tidal volume increases, minute ventilation increases because progesterone increases the central drive. These are all the changes. You can see respiratory rate increase, tidal volume is more, minute ventilation and everything is more. Again, I will come back to these things. So increased minute ventilation, increased PaO2. And if they start to breathe, they will wash out carbon dioxide to come PCO2 to 30, and there is some respiratory alkalosis. This bicarb excretion, which comes to come back the pH to normal. There is one more problem. This increased minute ventilation may hasten inhalational induction, usually when patient is breathing spontaneously. So this is little rare in pregnant patients. Now, if you see the central nervous system, the neuro changes are very subtle, very minimal. There is an elevated pain threshold. They tolerate pain better. There is an increased spinal dynorphin. There is an upregulation of descending inhibition. Why all these things should take place? They should withstand labor pain better. This is a natural thing given by God. There's one more thing. There's inhalational agents. They are more sensitive. And labor analgesia, I think, see, for example, 1 minute, Ollie. So many phones are there. Inhalational agents, that is why we are slightly scared about giving in as a labor analgesia. We may not know, even 0.6% isoflurane may be a little risky. There is a reduction of MAC. This is relatively pharmacological, so I will touch and go. Now GI tract, appetite is increased. There is a sense of taste may be blunted and gallstones formation is increased. See, gastric emptying time may not be altered except in labor. There is one subtle point that I want to tell is striated versus smooth. All these progesterone will cause dilatation of smooth muscles and not striated muscles. Now we have an upper esophageal sphincter and a lower esophageal sphincter. Lower esophageal sphincter is mainly smooth, while upper esophageal sphincter is mainly striated. So the regurgitation may come, but still we have one more safety mechanism of upper esophageal sphincter. And volume and acidity may not change. Consider all pregnant patients as full stomach. Now, liver blood flow may not be changed. The liver blood flow, portal compression, varices, and perianal hemorrhoids. The serum cholinesterase levels fall by 24% during the first trimester, but squalene, no problem. The kidneys, they are enlarged. There is a smooth muscle dilatation. Ureter bigger, may be prone for UTI. The tests are decreased. Creatinine, urea, and all are decreased. There may be a renal glycosuria. That we have to know. Hematologically, patient is having anemia of pregnancy because blood volume increases by 45%, but red cell volume only increases by 30%. This erythropoiesis is stimulated by human placental lactation. So blood increase, blood red cell increase, plasma is more. That is why we get physiological anemia. You can see here. Hematopoiesis outstrips iron supply. So many times iron supplements are necessary. So you can see this WBC count is normal, but may rise in labor. So now already we got told vasodilatation may cause a feverish sensation, and labor pain may also WBC count is increased. Fever with leukocytosis may be normal in late pregnancy and labor. So that is we have to understand. Coagulation. So platelets may be immature and may decrease. We can see this is what is called gestational thrombocytopenia. Many patients now, because after the dengue, now the gynecologists have started doing platelets after 9 months. There are many patients which come with 90,000, 1.2 lakhs. And if you go into the history, there is nothing. So all these patients come under the category of gestational thrombocytopenia, which is physiological, doesn't need any treatment. They go for a low-grade DIC. All coagulation factors are increased except some 11 and 30. So they are more prone for thromboembolic complications. Another thing is pregnancy is a diapetogenic state because human placental lactogen breaks insulin. So they are prone for ketosis. The average blood glucose is more. They are prone for a diabetes. A normal pregnant woman is euthyroid. Free thyroxine is the best test they say. Now they say you have to keep the TSH below 3. There are a lot of changes with skin which we will omit. There are some changes with increased thickness of cornea with a decreased IOP. Now you see, now we are having a center of gravity like this, but after the baby comes, the center of gravity goes over the leg. For that, the bone has to change. That is one. Number 2 is there is a relaxing because all these pubic symphysis muscles have to be relaxed slightly so that the vaginal delivery has to happen without much discomfort. But this may cause an unsteadiness of gait and trauma. You all get a difficult regional, we all know, because many patients are given in sitting in cesarean sections because there may be edema, they may not be difficult to position, and the big thing, there may be labor pain and epidural pressures, nobody knows because if you have a pressures, this may not work well. So loss of resistance, so many gives because of the edema. So we have to be absolutely diligent. Our thing should be absolutely diligent. So now you have to think physical changes. Another uterus big, diaphragm is pushed. All these changes take place after 25 weeks. They are physical changes. But physiological changes, cardiac output increase, blood volume increase, will start by 6 to 8 weeks. This is what we should remember. All physical changes will change by 24 to 28 weeks, while physiological changes can start by 6 to 8 weeks. Now, maternal physiology, what to know and why. I will go in a different way now. Now the baby is in the uterus. Now it has to get accommodated. The uterus has to become bigger. Is it okay? Now, Kripa sir, am I audible?
Yes,
Kripa
sir.
sir,
Yes,
am
sir.
I?
Yes, sir. Well audible. No problem. Go ahead, sir.
Okay. Now, this is the most important thing. The baby has to come in utero and it has to grow. It has to get accommodated because it grows. And uterus has to become big. And it has to get nutrients. So these are all the basic things. And after that, the mother has to deliver normally and the mother has to have a decreased PPH. Now you go see, blood volume increases. The blood volume increases, it has to supply the baby. Blood volume is increased and RBC is also increased now. It may become more viscous. It is difficult to travel. So it has to increase and it has to travel easily. These things are essential. So RBC increase is not as much as plasma increase. So it becomes more dilute and still RBC is more. So RBC is there, but still easy to go to the baby. Another point is the blood volume increase will compensate for the so-called PPH. Even 1,500 ml of blood loss postpartum is okay. Now, the blood volume is increased. Blood volume increase and I where to keep it. So it needs vasodilatation. Vasodilatation is done by the progesterones. So this vasodilatation keeps the blood volume. If the vasodilatation is happening to keep the blood volume, it may not increase the CVP at all. Vasodilatation is not happening, blood volume is more, the CVP may rise. But vasodilatation is happening, everything is easy to be in, so CVP does not increase. If low blood volume has come, how does the heart has to push? So the cardiac output has to increase. This cardiac output increase is done by both heart rate and stroke volume. Both will rise to increase the cardiac output. Now the cardiac output is increased, the blood volume is increased. It has to push. So much of push, again, suddenly from 4.5 to 6.5 liters, it has to easily push. So the systemic vascular resistance has to decrease. This SVR decrease is caused by one vasodilatation, another is by your placental circulation, which is of low resistance. Baby, a placental circulation, if it is going to be of high resistance, there is no use. So placental circulation is low resistance. There is a progesterone-induced vasodilatation. So the cardiac output is easily pushing all the things to the baby. Now, the baby needs so much of blood. That is okay. The baby also needs more oxygen. So what happens is there is a hormone-induced stimulus of the respiratory system. The patient breathes faster. RR is raised and tidal volume is raised. Both are slightly raised, but RR is little less. So respiratory rate, so minute ventilation rises. That we have seen. So oxygen PaO2 can increase even from 95 to 105. It goes above 100. And they start slightly tachypneic or slightly more tidal volume. So minute ventilation increases. That is very subtle. We cannot find out. So the oxygen is more. If they start breathing, the CO2 will fall from 35 to 28. So this change has to take place because this patient is breathing slightly higher on a higher alveolar ventilation. So CO2 excretion is. So this patient is slightly going for a respiratory alkalosis, but that doesn't happen. The kidneys wash out bicarb, and bicarb level may come from 22 to 18 or 16. So these are all the changes now take place. Now, okay, the coagulation process has to be hypercoagulable because these patients doesn't need much of blood loss. They have to decrease the PPH. So automatically God has given as all clotting factors are increased and coagulation is stimulated. As soon as the baby is delivered, the PPH is less and the blood loss is less. So these are all the essence. And now, see, now kidneys have more blood flow. And the resultant is creatinine is normal to less normal. If you see a creatinine of 1 in a pregnant 8 months, you have to be very careful. It is around 0.5, 0.4, 0.6. Or 1 or 1.2 is not normal in pregnancy. That is what, because kidney is having more blood flow and your values are little less. Now, there are a lot of changes in epidural fluid and spinal fluid and local anesthetic sensitivity. So there are physical and physiological in regional anesthesia. Physical in abdomen, intra-abdominal pressure rise action, epidural pressure rise action, spinal fluid becomes more narrow. So we need to give less drugs, local anesthetics. But this is also a physiological element of your progesterone causing local anesthetic sensitivity to increase. So this is around 30 to 20 to 30%. This is around 15 to 20%. So you may need to give a local anesthetics 40% less. For example, you are giving a normal appendicectomy, 25-year-old female, you may give 3.5 ml of bupivacaine. But if you come to a same level T6 in a pregnant, you come down to 2 or 2.2. So this is caused by one physical, another is physiological. Epidural and spinal fluid changes, and there is a local anesthetic sensitivity, which is physiological. So one more thing, they may need to tolerate better. So the pain threshold is slightly higher, and relaxants and dynorphins are there. Dynorphin is basically an endogenous morphine. So it's an natural analgesic. So this is slightly higher. So relaxing smooths the pathway. So they are relaxed. Easy to go, baby, and there is less pain. So this is what is the natural God's gift to mothers to normally accommodate a baby and get it out normally without much bleeding and with all the physiological changes to accommodate a well-growing, healthy baby. What is the carry home message? Thank you all. Thank you, sir.
Thank you, Partha. Nice presentation. Partha, I have a doubt. Can I ask?
Yes.
So you talk about the supine hypotension symptom of pregnancy.
Yes.
So how many of us are practicing it, that wedge or the table tilt? How many of us practicing that?
We are practicing. We are practicing, but in the periphery, there is less practice. There is one more thing in that. People do very fast surgery. See, what is given in textbooks is many things is about 1.5 hours LSTS cases. So here hardly 15 minutes, 20 minutes. That is one advantage which what I feel. But practitioners outside keep wedge little less frequently.
Yes, the evidence also says you have to tilt up to above 15-degree tilt only relieves the uterine compression. But
yes,
is it
15 degrees
practice? Whether the obstetrician will be comfortable with the 15-degree tilt?
So sometimes obstetrician is not comfortable. I will keep till the rectus sheath is open. And after that, I will remove so that the obstetrician is comfortable with baby delivery. That many times I do.
Okay.
Because at least for some time till painting and all, the wedge is there. And after that, skin incision wedge is there. Rectus is open. They are going to deliver means I will remove the wedge for the sake of the comfort of the surgeon. One thing what I want to tell the PGs is safety of the patient is the #1 priority. Comfort of the surgeon comes next. That has to be put into the mind.
Okay, Partha, for the evidence-based study, the 15 degree is not enough. They say it is nearly 30 degree only relieves the compression of venous compression. Can I share one slide? With your permission?
Yes. Or see.
Okay. So here there is a CT view of 0 degree tilt. There is a complete compression. Then 15 degrees tilt, the aorta only relieved, the venous still compressed. So 30 degree tilt only the venous is relieved. So whether this 30 degree tilt of table is possible in our practice, we have tried. See, this is the 15 degree tilt. Somebody has to be by the side of the patient to hold the patient on the table. Then 30 degree, it is unimaginable. So three persons are needed to hold the patients on the table. So, pelvic wedge, there is not much tilt. So, not just for the practitioners. So the evidences, coming to the evidences, only the 15% of the tilt is achieved by only the 21% of the anesthetist. Only 3% of the obstetrician tolerated that. And 76% of the patients feel discomfort in the tilted position. So in practical purposes, it is complete tilt of 30 degrees not possible, I think. And on evidences also says there is the Cochrane Library database, that is the systemic review says there is a limited evidence to support and clearly disprove the value of the use of tilting the flexing of the table for the use of wedges and cushions to use mechanical displacers. This is for some evidence-based only.
Nice article, sir.
How to okay.
Any queries from the delegates?
After that, come out of the slide share. Okay. So this is for some evidences says there is tilt is most important in patients who are hypovolemic. In hypovolemic patient, tilt is most important. In normovolemic patients, the wedge or the table tilt is not necessary according to the evidences. But we cannot assess which patient is normovolemic, which patient is hypovolemic. So safely we can go for a wedge. My concluding opinion is safely you can go for a wedge. How much is possible with the comfort of the obstetrician, with the patients, and for the comfort of the anesthetist. So okay.
Can I tell one more point in this?
You go on, go on.
Can I tell one more point, sir?
Yes, Partha, yes, Partha.
See, in the patients with severe hydramnias and patients with the twins, it's a must. Because definitely just, yes, it's a must. There is no doubt. Twins, as soon as you put the position, the BP will be 60. Unless you keep a wedge, you have to keep the wedge.
Definitely. Multiple pregnancy. So you have to keep the wedge. So safely you keep the wedge for all patients. So that's the underlying thing we can advise for the practitioners. Am I correct? Partha? So any other questions?
In the chat box, no questions, sir. I think everybody is convinced with the talk and everybody is well versed with the maternal changes in pregnancy and its anesthetic implications. I have very few queries because I am basically a cardiac anesthesiologist, almost 21 years out of pregnancy anesthesia. The only evidence I was there with my wife when she was delivered, that time only I come across that pregnancy anesthesia almost 14 years back. You said about ECT changes in maternal women said. In that you have noticed 78% of the cases WPW syndrome. Does it relate to the maternal changes during pregnancy or hormonal changes during pregnancy, or it is an observation?
We have observed like this in more than 500 normal pregnancies without any heart disease.
Yes, sir.
We have found out this 7 to 8% are having WPW syndrome. And these patients, if you follow up, there is a just increased incidence of tachycardia, not arrhythmias. Basically, after the spinal, they go to a rate of 140, 150 and all, and after that they settle down. So these things are there in these patients. WPW. These things are decreased after postpartum. Normal becomes normal after postpartum.
That means that it is related to the hormonal changes during pregnancy. That is what you wanted to tell.
Yes.
That is a news to.
During cesarean section, it's drug induced or during the antenatal period, the WPW syndrome.
Antenatal.
Antenatal. Okay.
Antenatal.
Yes.
Normal persons in 22 to 24 weeks.
Okay.
And during pregnancy, you said about during labor, the WBC count is increasing and ESR, CRP, everything is increasing. And fever with leukocytosis is a normal one. How to differentiate from that peripartum sepsis and the normal term labor?
See, this venodilatation and vasodilatation these changes will slowly come down immediate postpartum. So all this fever is more in the antenatal period. Fever and all these things are more in the antenatal period. And another thing is about the sickness. Peripartum fever and minimal, it will take minimal 6 to 7 days. Fever infection on the second day fever, post-op fever that day I talked, somebody was there, I know. Second day, third day fever and all is unlikely to be due to infections. So it takes at least 4 to 5 days to have these things. By the time at least the patient has to be really seen to know, really we know that this patient is a sick patient and this patient's WBC. Another thing is the WBC count will not go beyond 13,500 or 13,000. It will not go to 19,000, 18,000 and all in normal. And fever may not go beyond 99.5 or something like that. 101, these things all makes pathological. So around a feverish sensation, maybe with a leukocyte of 12,500, we can think as normal.
And one more thing about the GTP, sir. Gestational thrombocytopenia.
Yes.
Is it a routine occurrence or it is?
we are seeing a lot of cases now because after the dengue phenomena, people start to take a platelet count on every pregnant patient at the time or 2 days prior to delivery now. So this comes suddenly, these things, before that we don't take only. We don't take this platelet only. But nowadays people are taking platelets before delivery and say they see 95,000 and all these things are there. But if you go into the records and evidence, there is a lot of, there is no treatment and it always goes normally after the pregnancy. GTP is normal occurrence. Now we are saying lot. At least 1 month, 3-4 cases I am seeing.
Then gestational thrombocytopenia, how lowest safe limit? I have seen gestational thrombocytopenia with 50,000. And we have
seen 65. Yes.
Proceeded with spinal anesthesia and
yes. Nothing.
So, many of them afraid of that, they started transfusing platelets. Number of platelets, 10 units, but nothing will happen. The platelet count will not increase. So that is the peculiarity of the gestational diabetes. Then there is one
question from the chat box. Any changes or precautions for central venous line during pregnancy?
Difficult to position in this thing. Otherwise, venodilatation will be there. All CV existing central lines are a little bigger. Only if it is breast and neck, if you are able to position, it's normal. And with ultrasound, there is no change. With ultrasound, we can take it within 25 to 30 seconds. No problem.
So the peculiarity is, even though the blood volume is increased, the CVP is not increased because
normal
of dilatation. And another thing is, in pregnancy, there is a rotation of the carotid artery comes just anterior. So it is we have to be cautious in doing CVP in these patients. We have to do only under the ultrasound guidance. That is one thing of cannulation in pregnancy.
I think no more questions, sir. We'll move on to the next topic, sir. Thank you, sir. Thank you, Dr. Pathasari, sir. Thank you for the excellent talk, sir.
Well done.
Yes, sir. Yes, sir. Proceed for next talk.
Yeah. Kumar, if you permit me, I may have to go to hospital for an emergency.
Okay, sir.
I may leave the meeting and wish the best for ISA Salem. Thank you. I might miss part of your talk, but I will, while traveling, I will listen on the phone.
Okay.
Thank you.
Thank you, sir. Thank you, sir.
You will leave now. Thanks. Bye. All the best.
Edward, sir, proceed for next talk.
The next speaker, Bhavani, is Associate Professor of Vellore Medical College, and he is interested in critical care and mostly he is interested in teaching the postgraduates. Welcome you, ma'am. Bhavani, ma'am.
Good evening, sir. Good evening. Thank you. I would like to thank the ISA Salem branch and state ISA office bearers for giving me this opportunity, sir. Can you all hear me, sir?
Yeah. Well heard. Proceed.
So, First of all, I would like to thank all my teachers and my seniors in the anesthesia fraternity on the eve of World Anesthesia Day. And today's my topic is labor analgesia. The overview of my topic is to learn the different modalities of labor analgesia, to focus on the time-tested lumbar epidural for labor analgesia, and briefing on the troubleshooting, and also about the recent advances and few terms used in labor analgesia. Going back to the history, the first person who gave labor analgesia was James Young Simpson, who gave labor analgesia for a woman with rickets with severely deformed pelvis. The mother delivered pain-free in spite of being having so many complications. And the other person of mention is Mr. John Snow, who has a name in the royalty for giving chloroform for Queen Victoria. But then from day one of labor analgesia, there were so many controversies. The clergy people thought it was Eve's divine punishment to have pain during labor. So they did not want it to go. And they did not want the doctors to take care of the pain. Next, many obstetricians thought labor analgesia was unphysiological. And even other members of the other fraternity thought it is dangerous to give some drugs and obtain the analgesia. But then, even before all these people threw the controversies, Simpson told, even if the doctors opposed, a day will come when the patients themselves would ask for labor analgesia, and it came out true. Because in 1847, Fanny Longfellow, wife of a poet, she herself volunteered to have labor analgesia. And in 1853, after having a chloroform from John Snow, Queen Victoria told it was a blessing. And this labor analgesia was constantly getting evolved with Paul Zweifel finding out the placental transfer of drugs. And the hallmark of labor analgesia, the research in labor analgesia took a big turn when Virginia Apgar found out objective criteria for neonatal assessment. So based upon this, people were able to devise different plans of labor analgesia because now this criteria made way for the safety of the newborn. From 1900 to 1996, there are so many inventions and discoveries in labor analgesia which need a mention. Now coming to the labor analgesia proper, what is labor? Labor is said to occur when the woman is having contractions once in every 3 minutes, lasting for 45 seconds, the progressive dilatation of the cervix and the progressive descent of the presenting part. But why should this labor have pain? Because in the first stage of labor, when the patient is having, when the uterus is contracting and the cervix is dilating, the patient will experience dull, aching, poor localized pain due to the visceral C fibers, which is transmitted from T10 to L1. So this is the first stage of labor pain, which is mostly visceral pain. During the second stage, the pain is somatic because this occurs due to the distension of the pelvic floor, vagina, and the perineum. Now, these are conducted by A delta fibers, which enter the spinal cord at the S2, S4 level. So, is analgesia during parturition necessary? The people say the intensity of labor pain is a human body can bear only up to 45 Dell unit of pain, but then a woman experiences 57 Dell unit of pain. So, which means it's almost like 20 bones cracking together. So, in this Megel pain questionnaire, you can see that labor pain occupies the topmost position. So, the pain itself is very distressful for the delivering mother. Apart from that, there are certain adverse effects of this labor pain. In the cardiovascular system, the increased maternal plasma catecholamines, cortisol, ACTH, and cause more problems. And there is increased sympathoadrenal activity, which may lead to uncoordinated uterine activity and reduction of uterine perfusion. So when this nociceptive input is stopped, then the patient, the uncoordinated uterine contractions may be converted to normal contractions and adequate placental perfusion may be maintained. We can see in this study, like the maternal catecholamines were measured when the patient before epidural and after epidural. You can see the there's a significant fall in the plasma epinephrine and the norepinephrine levels. In the respiratory system, there is increase in the minute ventilation because of the pain, and which may lead to hypocarbia, increased oxygen consumption, and compensated metabolic acidosis. And there will be hyperventilation in between the contractions, causing hypoxemia. Also, there is leftward shift in the maternal oxyhemoglobin dissociation curve, so increasing the maternal affinity for oxygen, thereby reducing the fetal oxygen supply. So all these bad effects can be obtained by giving labor analgesia. And this stress-induced hyperglycemia and lipolysis will cause more acidosis, and these acids cross the placental barrier and cause fetal acidosis and increase the fetal oxygen requirement. So labor analgesia, it causes reduction in the maternal plasma concentration of catecholamines. It increases the uteroplacental perfusion. It causes effective uterine contractions. So analgesia is required during parturition. It is beneficial in all patients universally, especially in those with cardiovascular and respiratory problems and those with pregnancy-induced hypertension and diabetes. Now, what are the modalities of labor analgesia that are in our armamentarium? There are non-pharmacological methods and pharmacological methods. The non-pharmacological methods may be mind-based or skill-based, and pharmacological methods are systemic and regional. So non-pharmacological methods of labor analgesia or is something like the emotional support, massage, aromatherapy, audio therapy, and hot and cold therapy. Now, more specialized techniques like hydrotherapy, intradermal water injections, biofeedback, transcutaneous electrical nerve stimulation, acupuncture, they also have a say in controlling the pain during labor. Mind-body interventions include psychoprophylactic methods like breathing exercises, deep abdominal breathing, hypnosis, and yoga and music therapy. And acupuncture is used mainly in China, but then they use subtle needles, and this is based on the gate theory. And transcutaneous electrical nerve stimulation is a very common modality of labor analgesia in few institutes. Now, coming to the pharmacological methods, the systemic pharmacological techniques include intravenous agents and also inhalation agents. The regional techniques include uraxial blockade and nerve blocks. What is the characteristic of a technique which is the ideal labor analgesia? So it should have effective pain relief, it should be safe, it should minimize the effects on the progress and outcome of labor, it should cause minimal effects on the fetus and the newborn, and it should cause minimal maternal side effects. Now, the first set of drugs, first set of technique is involves the systemic opioids. So there is a whole lot of drugs in our, this is according to Chestnut textbook of obstetric anesthesia. We can find so many drugs which were tried all the time. And one drug that's really stood the test of time is meperidine or pethidine, which is given in the dose of 25 to 50 milligrams IV or 50 to 100 milligrams IM. And the duration of action is 2 to 3 hours. But this drug is notorious for causing neonatal depression. So the obstetrician usually plans the injection so as to deliver the baby within half an hour after injecting, or she will wait till 3 hours before delivering the baby. Fentanyl is another one drug which can be commonly used because it is very, it's got a quick onset of action, but one disadvantage is very short acting. And the other butalphenol is another beautiful drug which can be used for labor analgesia, but then the ceiling effect on respiratory depression is one which holds it back. Now, the newest drug in the parental opioid armamentarium is remifentanil, which is an ultra-short acting opioid of fentanyl, derivative of fentanyl, and it is the prolonged administration doesn't cause any accumulation because it is actively metabolized by esterases. So the fetal exposure is very minimal, and it is commonly used in the patient control analgesia techniques. It is given as a 25 microgram bolus and 0.05 microgram per kilogram per minute infusion. The lockout time interval is 5 minutes. Now, we have so many drugs, but why don't they stand good? Because they have got so many disadvantages. Although narcotics provide both analgesia and sedation, they cause maternal orthostatic hypotension, nausea, vomiting, decreased gastric emptying, dysphoria, drowsiness, hyperventilation. In the fetal, there's decreased beat-to-beat variability of the fetal heart rate, and after birth, there may be respiratory depression and neurobehavioral changes. So, the next step of how it evolved the parental opioids was patient-controlled analgesia. This is a commonly assumed term because this denotes on-demand intermittent IV administration of opioid under the patient control with or without a continuous background infusion. This technique is based on the use of a sophisticated microprocessor controlled infusion pump that delivers a pre-programmed dose of opioid when the patient pushes a demand button. So this is how it looks. The infusion pump is controlled by a by a device which has buttons for the determining the dosage and the lockout interval. So what is this lockout interval? This lockout interval is specific for each drug, and when the patient is handling the device, she has to whenever she feels the pain, she has to push a button. But then if she has a tendency to have more pain, she may push the button again and again. So to prevent the drug overdosage, each drug has got a lockout interval based on the duration of its action. What are the advantages of patient-controlled opioid analgesia? Superior pain relief with lower doses of drug, less risk of maternal respiratory depression, less placental transit of the drugs, and less need for anti-emesis, and higher patient satisfaction. This is very important. Patient satisfaction puts out 50% of the pain in laboring patients. But the limitations, still the appropriate drug dose and the dosing schedule have not been yet defined. So it still is unread part of labor analgesia. Now coming to the inhalational agents, from the invention of nitrous oxide and to the newer fluorinated agents, this has been tried for labor analgesia also. But then only two agents are commonly used. One is Entonox, which contains 50% nitrous oxide in oxygen, which provides analgesia within 20 to 30 minutes of inhalation. Like the patient has to breathe through a mask when the pain starts, so that when the pain peaks, at the same time, the nitrous oxide level also peaks in the brain, so that adequate analgesia is obtained. But this needs a special device with a demand valve, because the patient, only if the patient breathes, then the Entonox is taken inside. And that demand valve, otherwise, the nitrous oxide may go on continuously and the patient may become stupid. So the demand valve is very important in this apparatus. Next is COX, which contains with sevoflurane and oxygen 0.8%, and this also needs a specialized equipment. Now coming to the regional labor analgesia techniques, according to Reena et al., she has identified a few time-tested techniques of labor analgesia, regional analgesia techniques, and also some newer techniques. So the commonly used terms are lumbar epidural, combined spinal epidural, and patient-controlled epidural analgesia, and computer-integrated patient-controlled epidural analgesia. So coming to lumbar epidural, which is quite popular in our setup. So when to place a labor epidural? The American College of Obstetrics and Gynecologists and the American Society of Anesthesiologists have jointly emphasized there is no need to wait arbitrarily till the cervical dilatation has reached 4 to 5 centimeters. The maternal request is a sufficient indication for pain relief and not the cervical dilatation, which was previously the indication for initiating labor analgesia. So step 1 of lumbar epidural anesthesia, communication between the obstetrician, pediatrician, the floor nurse, the patient, and her relatives, because the obstetrician should be convinced about and the coexisting diseases of the patient should be got from the obstetrician, and the pediatrician should be aware if you are going to use any opioid in our regimen, and the nurse should be there for monitoring the patient continuously, and the patient should be first willing, and the relatives should know the pros and cons of labor analgesia. Step 2 is pre-anesthetic evaluation, which starts from the history and probe into the past medical illnesses of any bleeding diathesis, CNS problems, or heart disease, or any drug allergy. And then you have to look up into the investigations. Now, what are the indications for neuraxial analgesia? Maternal request, hypertensive disorders of pregnancy, pre-existing medical disease, multiple pregnancy, previous cesarean section, prolonged labor, deterioration in fetal well-being. The contraindications are maternal refusal, coagulopathy and thrombocytopenia, local or systemic infection, inadequate staffing or facilities, increased intracranial pressure, and uncorrected maternal hypovolemia. Now we are convinced like that this patient is okay for labor analgesia. Now we have to plan the appropriate procedure and inform and explain the procedure to the patient and get her consent. Then we have to prepare the equipment for the procedure and to tide over any emergency that may occur during the procedure. And we need specific monitors for the mother and the fetus. then we proceed for the. So this is how the final plan looks. The mother is feeling uncomfortable because of the contractions. Now we are going to initiate lumbar epidural. So we make sure she has got an IV line and a nurse to monitor, and there is a specific monitor for the mother to measure her blood pressure and her saturation, and the fetal heart monitor also. Now coming to step 4, we have to maintain strict asepsis, and in our setup, especially in institutions and small hospitals, it is always better to do in the theater, because the theater or the labor room where facilities for maintaining asepsis and also facilities for initiating any resuscitation protocol is available. And next we have to position the patient according to our convenience and also according to the patient's convenience. And we have to reassure and tell her that it is going to be a little painful procedure, and commonly the catheter is placed at L3, L4, and when you place the catheter, it is kept only up to 5 centimeter epidural space to avoid coiling. Now, sitting up and lying on procedure, evidences say that while sitting up, the veins are engorged a lot, and then more chances of inadvertent vascular puncture is possible. Lying on one side, that position is the best for the patient and also the anesthetist. But in the case of a difficult lumbar epidural, we can always make the patient sit. So now while after placing the catheter, we have to plan the test dose. Historically, we usually give 1.5% of lidocaine with 1 and 2 lakh adrenaline as test dose. The lidocaine to check the motor blockade, to check the intrathecal placement, and adrenaline to check the intravascular placement. But then in labor analgesia, we are not going to use so much of drug finally. So we are going to use in low concentration. So, and adrenaline cannot help because the patient may already have tachycardia because of the labor pain. So the adrenaline induced tachycardia cannot be differentiated from the pain induced tachycardia. So adrenaline has no scope. At the same time, the 3 ml of lidocaine is too much for laboring patient. So now how do we test the placement of epidural catheter? For every dose administered via an epidural catheter for labor analgesia, whether to initiate a block or treat breakthrough pain should be treated as a test dose, as catheters can migrate intrathecally and intravascularly despite initially placed correctly in the epidural space. So present methods, now after testing after ruling out the intravascular and intrathecal placement, now we can initiate the block with 0.125% bupivacaine or 0.125% to 0.2% ropivacaine, 10 to 15 ml. We can add fentanyl up to 2 microgram per ml. Then we should also plan our maintenance dose. This initiation of epidural and spinal labor analgesia is, the dosages are clearly given in Chestnut. Please, everybody can go and refer that book. And now for maintenance doses, one which is a workable doses, maintenance can be either given as bolus or continuous infusion. So if you're going to give us bolus, bupivacaine 5 to 10 ml of 0.125% to 0.375% solution every 60 to 120 minutes will be needed. And though the duration of action of bupivacaine is around 2 hours, to prevent the breakthrough pain, to prevent the patient from getting pain before the next dose, it's always given at 60 to 120 minutes. And ropivacaine is given in this dose. And if you're going to give bupivacaine infusion, it is given in the dose of 0.0625% to 0.25% solution at the rate of 8 to 15 ml per hour. But considering the cardiotoxicity of bupivacaine, now levobupivacaine is taken over, and levobupivacaine is given in the dose of 5 to 10 ml of 0.2 to 0.25% solution every 60 to 120 minutes. Infusion also can be given. And this is how continuous epidural is given. After putting the catheter is connected to an infusion pump. And this study, we can see how this low dose local anesthetic, when combined with opioid, has got better effects than pure local anesthetic. See, in the first figure, you can see bupivacaine alone, next bupivacaine and fentanyl, and next you see low dose infusion. In the low dose infusion, the spontaneously delivering patients are more and instrumental deliveries are less than in the traditional large dose local anesthetic. Now, intermittent bolus and continuous epidural infusion. So what is the advantage? So intermittent bolus injections are nothing but first you initiate the block, and then every 1 hour or every 45 minutes, you give again bolus till that baby is delivered. In continuous epidural infusion, first you put the catheter, you give the bolus, and then you connect it to the infusion pump, and there will be a continuous supply of epidural drug. So now what is the advantage of intermittent bolus injections? There will be uniform spread, because when you give it as a bolus, the current with which the drug enters the epidural space will help in the uniform spread over a large area, and it provides superior quality of analgesia. But the disadvantage is breakthrough pain. This can be mitigated by continuous epidural infusion. So a combination of intermittent bolus and continuous epidural infusion is what is required nowadays. And another technique which is now come into vogue is combined spinal epidural analgesia, because this is very rapid, very reliable, because epidural is a blind procedure. We won't know whether the catheter is inside. If the patient has pain, is it due to the wrong placement or because it is intravascular? It is not very clear when you place a epidural. But when you give a spinal drug, the onset is immediate, so we will know. The patient satisfaction is also very good, and then you can use some sort of analgesia is definitely possible before we can activate the epidural. So what are the methods which can be used to perform a CSE block? Epidural catheter insertion followed by a spinal needle placement at the lower interspace. Epidural needle is inserted beside the spinal needle at the same interspace, or the most commonly used needle through needle technique, where the epidural space is identified with an epidural needle in the standard fashion. The needle then functions as an introducer for a long, small gauge pencil point spinal needle. So this is how this occurs. Needle inside needle. The tuhoid tip is placed in the epidural space. Through that opening, the smaller size spinal needle goes and pierces the dura mater, and then the spinal needle is taken off and the catheter is inserted into the epidural space. So this is how the combined spinal epidural needle looks. Now, what are the advantages of CSE over lumbar epidural technique? This has got rapid onset of analgesia, very reliable, and effective sacral analgesia is possible. In lumbar epidural, sole epidural analgesia, then the sacral sparing can occur. So that is one big issue when the patient is in the second stage of labor. So that can be obtained when you use CSE. But the disadvantages, failure of the catheter is again possible here. Post-dural punctural headache is also a problem, and it's very difficult to test the epidural catheter because already the patient will have motor blockade, and it is known to cause fetal bradycardia, and all other problems of spinal can occur in this. Patient controlled epidural analgesia is another advancement in epidural analgesia, and it gives good analgesia and patient autonomy. And here again, there's a patient satisfaction that wins over the simple lumbar epidural technique. Here we can see in this patient controlled analgesia, the pain relief index is high than the conventional technique. So patient controlled epidural analgesia, as like patient controlled analgesia in opioids, is superior to the regular methods. Now, the newest modality is computer integrated patient controlled epidural analgesia. Here, a laptop or a computer with a programmed algorithm is connected to a standard epidural pump. Now, the computer program automatically adjusts the background infusion rate based on the analysis of the patient's local anesthetic requirement in the last 1 hour. So this is based on artificial intelligence, and this is very much associated with lesser incidence of breakthrough pain because the computer totally analyzes all modalities of pain in the particular patient. This is how the algorithm works, and this is how the device looks. Now we have placed the catheter, we have initiated the block. Now it's not without complications. So how are we going to manage the complications? Whenever hypotension occurs, do complete, uterine displacement, IV fluids and vasopressors as like any other spinal anesthesia. Accidental dural puncture and post-dural puncture headache is also possible here. And patient is recommended bed rest, fluids, oral caffeine, non-steroidal anti-inflammatory drugs, epidural blood patch, And cosintropin is a synthetic ACTH analog, which is now recently used for PDPH. And if the patient has got pruritus because of intrathecal or epidural opioid, he can give naloxone. Naloxone is a very short-acting drug, so it's better to give in the dose of as an infusion in the dose of 0.25 to 1 microgram per kilogram per hour. And this is the best dose, because if you increase the dose, the analgesia also gets antagonized. And now local anesthetic systemic toxicity can occur. We have to be ready with anticonvulsants, 100% oxygen, and we have to initiate the ACLS protocol in case the patient defibrillates. I mean, in the patient throws arrhythmias. And then lipid emulsion and 20% lipid emulsion in the dose of 1.5 ml per kg for refractory toxicity can be tried. And this also should be kept handy. Inadvertent high block can occur when the catheter migrates subdurally. So in that case, we have to be ready for ventilating and maintaining the hemodynamics of the patient. And coming to the other region, paracervical block provides satisfactory pain relief during the first stage of labor, but then does not relieve pain during the first stage and the second stage. So next block is the pudendal block. The pudendal block works for the second stage, and also when their instrumentation is done. But these blocks are not are highly, I mean, needs expertise to be performed, and most of the time it is the obstetrician who does this. And but what are the disadvantages of these regional blocks? There are chances of hematoma formation, infection, local anesthetic systemic toxicity can occur still because it is very near to the vessels, and it does not relieve the pain adequately. Coming now, lumbar epidural is done. So there are some myths, and we will now look at the evidences that are busting those myths. The myth number one is increased incidence of cesarean delivery occurs when you activate a lumbar epidural for labor analgesia, and also increased incidence of instrumental vaginal delivery occurs. But then in the study, they have clearly proved initiation of neuraxial analgesia even in the latent phase of labor, when the cervical dilatation is less than 4 cm, does not increase the risk at all. So this myth is busted. The second myth is increased duration of the first stage of labor and the second stage of labor. And this study, which studied the effects of labor progress and maternal neonatal outcome, they have found that overall evidence from literature suggests no difference in the duration of the first stage of labor, and effective neuraxial analgesia does increase the duration of the second stage of labor. The third myth is associated with future back pain, and there is no statistical difference in the incidence of back pain, disability, or movement restriction between women who have had epidurals and those who have not in this journal. And maternal hyperpyrexia and impaired breastfeeding, both these myths have been busted again by the study by Litton and Harpin. They have found out the epidural analgesia has been found to be linked with maternal pyrexia, which is unknown, but that is not going to cause any problem for the mother. And impaired breastfeeding, they have failed to demonstrate a significant association between epidural and less successful breastfeeding attempts. And coming to the recent advances, double catheter technique. This is one technique which I have been, I have used in 2 cases when GA was not possible, and we put a lumbar catheter. We put a lower thoracic catheter and a caudal catheter for a patient who went anterior perineal resection. Double catheter technique is now done for labor analgesia also. This cannot be done for every case, but then this technique is certainly useful in cases in which an extensive sympathectomy must be avoided, as in aortic stenosis or primary pulmonary hypertension. One catheter, during the first stage, the lumbar catheter is activated, and during the second stage, the sacral catheter is activated. This is mainly based on the low volume, low dose technique. And next is dural puncture epidural. In this, the spinal needle is put and the spinal dura mater is punctured, but then the catheter is placed in the epidural space. Now, the drug which is filling in the epidural space seeps into the spinal slowly, but without any guard, but that enhances the analgesia. So this is a very novel technique, and a lot of studies are to be done in this. A walking epidural has been there from twilight days of the twilight labor analgesia, which occurred with morphine and scopolamine in the early days. But then with the advent of combined spinal epidural opioid analgesia, this walking epidural has become a possibility nowadays. But even here, few reliable data is only so far available to say whether ambulation during labor is harmful or helpful. Next is remifentanil. In 2001, remifentanil came into vogue, but then it was not entertained. But again in 2018, they did a study and they found that although its analgesia is not superior to an epidural, remifentanil is an efficacious alternative for patients who have contraindications to epidural administration, including back problems, coagulopathy, and fixed cardiac output diseases. Ultrasound guided lumbar epidural is the newest. The ultrasound is used for placing a lumbar epidural because it has got specific advantages. It helps in identifying the midline in an obese pregnant patient. It tries to localize the epidural space so that the failed catheter is made minimal, and it also facilitates the placement of epidural needles in obese pregnant women and in patients with deformities like scoliosis. And it can be used as a teaching tool. But then disadvantage, increased procedural time, increased cost of the procedure, and it needs a lot of expertise. And this is how the bat wing appearance of the vertebra is seen, and the intrathecal space is identified here, and the catheter placement can be identified using ultrasound. And now coming to troubleshooting, Madam Surendra Gupta is one of the pioneers in obstetric anesthesia, and in her journal she has clearly given how to go about a failed epidural. But then this is so much information in a single slide, so I thought what we usually experience after placing the epidural catheter, sometimes you don't get the adequate pain relief. It may be due to the inadequate dose, or it could be due to the subdural placement. So subdural placement, the drug will ascend along in the subdural space, causing high spinal and weakness of the upper limb, but then it won't cause adequate pain relief in the lumbar segments. And when the patient has got breakthrough pain, when the patient, you plan some analgesia technique and the patient has got pain in between, it's always better to supplement with bolus than even if on a continuous infusion. And this bolus will take over a better, they will spread over a bigger area and prevent the breakthrough pain. During the second stage, in the patient complains of inadequate pain relief, it can supplement again with the bolus or try giving the drug in a semi-recumbent position. So these three things I have even tried in my patients. Conclusion: the delivery of the infant into the arms of a conscious and pain-free mother is one of the most exciting and rewarding moments in medicine. Thank you.
Thank you, madam. You have completely covered the whole labor analgesia. Partha want to know, there is one question from Partha. Is there any role of analgesia making dysfunctional uterine contraction to make better?
That is what any kind of analgesia can help that, sir.
Yes.
Because the increased sympathoadrenal activity is the main reason for causing the uncoordinated uterine activity. So thus, by preventing this nociceptive input, certainly we can try, sir.
Okay. Then no more questions in the chat box. So my question is, suppose you are attempting labor analgesia by epidural technique.
Okay, sir.
Consider the dura and CSF is pouring out. How will you proceed further, for the sake of practice?
Sir, like sir, that if the CSF is, when this has occurred few times when we tried anesthesia, providing anesthesia for cesarean, sir. So in labor analgesia, when it occurs, we can two things can be tried. One is the needle can be pulled out a little, and then you see if again CSF is pouring. But what happens is already the collected CSF around the needle will be coming. We cannot say whether it is the collected CSF or it is coming from the intrathecal space. So that we cannot account for. Next, in case we can, if at all that's a very deserving case and you really want to do I mean, we want to give analgesia for the patient, you can use it as a continuous spinal catheter also.
Yes. To avoid a post-dural puncture headache, you can thread the
Yeah,
catheter.
that is a real problem. But then as soon as the patient has got adequate, because we are giving spinal, as soon as the patient delivers, I mean, the pain relief will be very adequate. I mean, very efficient, so that we can remove the catheter once.
And
Yeah.
we can also try the epidural, the one space above also.
And the best thing would be, the most safe procedure would be to redo the procedures.
Yes. Any other questions?
One comment. It is an excellent presentation, Dr. Bhavani. As usual, like your previous presentation about COVID and anesthesiologist a few weeks back.
Thank you so much, sir.
Yeah, one more connected question. Do you practice labor analgesia in COVID patients?
No, sir.
Because you have to stay with the patient. That is why, out of
Yes,
curiosity,
sir.
I'm asking.
Yes, sir.
And number two, one query, you said about PDPH, you are using cosintropine.
No, I'm not in the literature.
Yeah, no,
sir.
you're not you are using, but
Yes, sir.
the said about it. Is it available and does it practice routinely? That is what my query.
I'll be happy if it is available, sir, because it's easy to give a drug than do a epidural blood patch.
Okay.
And even I'm doubting if remifentanil is available in India.
No, remifentanil is not available. That
Not
is not
available.
not available in India. That I know very clearly. But this cosintropine, does it available and does it practiced in PDPH? That is what my query.
No, sir, I don't think so, sir. But nowadays, the incidence of PDPH is very low because of everybody has started using the small size needles.
Okay.
And
another question is, for dural puncture epidural, what size needle you have to use for the dural puncture? That is spinal needle size. And which type of
27 gauge is what is given in book, sir.
7 has failure rate. 25 is the ideal length.
25, okay, sir.
Then another question is, suppose you are giving, which one is better, madam? Continuous infusion or intermittent bolus?
A combination of both, sir.
Bolus followed by infusion.
Bolus followed by infusion, and if in between, if the patient has breakthrough pain, again give one bolus.
So the advantage of infusion is you can overcome the breakthrough pain. Plus the intermittent bolus advantage is you can avoid motor blockade because it will dissipate into the nerves and the threshold for the pain relief will be reached quickly and it will be slowly waning off. So the motor blockade will be not much if you use intermittent bolus. And also you are giving intermittent bolus means the spread of dermatomes will be higher compared to the infusion. Infusion, the pressure by which you are infusing will be low. So the dermatomal spread will be low compared to the intermittent bolus. That's why they have come up with programmed intermittent bolus and PCA combined. The latest technique is programmed intermittent bolus. The intermittent bolus has advantage over the continuous infusion.
Okay, sir. Thank you, sir.
What about additives for the epidurals?
Additives, sir, usually opioids, alpha-2 agonist, even neostigmine is used, sir. I mean, but then commonly we use only fentanyl in the dose of 2 micrograms per ml. Other things I have not personally used.
And the opioid pruritus, we can use also propofol 10 milligram is also useful.
Epidural, sir?
No. Pruritus.
Yeah, okay, yes, sir. For pruritus, yes, sir, yes, sir.
How do you manage patchy epidurals during labral anesthesia?
Patchy epidurals, if the patient has got patchy analgesia, we can give a little more drug, either the volume or you can increase the concentration a little bit, sir.
Already you have exceeded the volume. What do you do now?
Then I'll reassure the patient, sir. I'll stand beside her.
You have to go to for some other
No.
Some other we can
in
give
that case,
or something else.
Yeah, I have read in one article that in patchy epidural, They infuse alpha-2 agonist dexmedetomidine intravenously.
Okay, sir.
That
Okay, sir.
augments the effect of your epidural anesthesia. That's why I asked that question. Okay, it's a good presentation.
Nice presentation, Bhavani madam. So we can conclude.
Conclude, sir.
Yes.
Yeah, we can conclude.
Yeah, thank you. Thank you.
Epidurals.
Both the speakers. Thank you very much, Dr. Partha,
Yeah.
Dr. Bhavani.
Partha is telling something. Partha is telling.
Yeah, please,
Yeah.
sir, please, sir.
In patchy epidurals, we usually add Entonox.
Antonox.
We usually add Entonox.
Okay. Right.
Entonox. Okay.
Okay. Thank you.
There are no further queries or questions from the delegates. We'll conclude the session. Thank you very much, Dr. Parthasarathy and Dr. Bhavani, for the excellent talk. And we had a very good interactions. Thank you, Salem City Branch, for the nice conduct. And once again, wishing you all a very happy World Anesthesia Day. Thank you very much. Have a good day. Thank you.
Thank you. Over to Lavanya, please.
Yeah, thank you, Dr. Kumar and Dr. Johnson for moderating the session. With this, we have come to the end of the academic session. We would like to thank Department of Anesthesia, VMKMCH, for jointly organizing this CME online CME meet along with Salem City Branch. We would like to thank Dr. Sudarshan, Dr. Prabhakaran and Dr. Ratna Kumar for Tamil Nadu ISA team for supporting all the scientific events even during this difficult COVID time continuously. And I would like again thank Dr. Kumar and Dr. Edward Johnson for moderating the session and making the event very lively with a useful discussion along with practical points, even for practitioners along with PGs. I'm sure the postgraduates would have enlightened with because the maternal physiology and the labor analgesia are the two important topics from the exam point of view and from the practitioner point of view. So I thank Dr. Parthasarathy and Dr. Bhavani for their excellent presentation and make the complicated subjects very simple terms. And we'd like to thank Mrs. Shilpa, who was our technical support person, and for making this event successful without any technical glitches. Thank you, Mrs. Shilpa. And I'd like to thank all the delegates who have spared their free time to log in and to listen to the meet and to participate in the discussion. Thanks, everyone. With this, we conclude this meeting. Thank you all.
Thank you. Good night. Thank you.
Good night. Good night. Kumar, good night.
Thank you, sir.
Edward, good night.
Right. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you. Thank you all.
Thank you. Thank you.
Thank you, Shilpa.
Thank you, sir. Thank you, ma'am.